So welcome to this tutorial on the PAINFREE Initiative. The PAINFREE Initiative is a quality improvement initiative that was developed by all the people that you see mentioned on the slide. They are representative from the emergency department, the Department of Internal Medicine, geriatrics, pharmacy, patient representative, and it is an initiative that is led by Dr. Suzanne Morin. In this presentation, we will introduce what is the PAINFREE Initiative. We will review principles of pain management in the emergency department. Hopefully, it will raise your awareness of the importance of documenting pain scores in the emergency, and it will provide information and recommendations for optimal pain management while patients are in the emergency department. So PAINFREE was developed because we know that skeletal fractures are frequent in older adults. We also know that pain is a major component of patients' experience. And finally, fractures and pain constitute major physiological and psychological stressors for patients. Okay, so just to give you some background, in 2009-2010 at the Montreal General in the emergency department, we reviewed the chart of 111 patients who were diagnosed with hip fractures. What we found is that 21% of the patients' assessments did not have a documented pain score using a valid scale. If we compared patients with normal cognitive function and patients with impaired cognitive status, the patients with the impaired cognitive status were less likely to have a formal assessment of pain or pharmacological intervention while in the emergency department. So what is the PAINFREE Initiative? It's a quality improvement endeavor which was funded following a competition to support large quality improvement initiative. This competition was called Challenge Q+, and the funding is provided by the MUHC Foundation as well as the Quebec Blue Cross. The overarching aim is to improve acute pain management for older adults, adults older than 75 years old, including those with cognitive impairment who present to the emergency department with a fracture. In addition, a second objective is to reduce adverse events resulting from the fracture and poor pain management, including worsening of mental status, length of stay, and return visits to the emergency department. We also want to empower patients and families so they can collaborate with healthcare professionals in pain management. And this will be done in all three emergency departments of the adult sites of the MUHC, the Montreal General, the Royal Victoria, and Lachine Hospital. So the PAINFREE Initiative is a multifaceted intervention. It targets nurses as well as physicians. It includes the development of PowerPoint presentations specific to each profession aimed at assessment, documentation, rapid and appropriate treatment of pain, as well as reassessment. Each profession, nurses and physicians, will be provided with some practical tool. For the nurses, we will distribute pocket cards that include a new pain scale to be used with the cognitively impaired patients, as well as automatic reminders for pain reevaluation built into MedSurg. The physicians will have access to structured prescription for analgesia 75 plus pain-free while the patient is in the ED, but also as a discharge prescription. We will provide patients with resources and support in the forms of fact sheets as well as access to a website, and we will target the emergency department environment by providing visual campaign with posters, lanyards, and messages on plasma screen TVs. So our goal is for the patient to be at the center of all interventions. And the interventions, again, will target the nurses, the physicians, the family and the caregivers, as well as the environment of the emergency department. So what exactly are we measuring? We will measure how well we treat the pain, and we will do this by looking at pain score documentation at triage and the administration of analgesia by the emergency department nurse. We will also measure documentation or evidence of worsening of mental status while in the emergency department, the length of stay, and return visits to the emergency within 7 days of discharge. Where are we getting the data from? At the MGH and RVH, mid-dose chart reviews will be done, and at Lachine, the SIRG as well as the medical charts will be looked at. The data is collected in 3 phases. We've already completed the baseline data, and I will show you this in a minute. And data will be collected again approximately 1 month and 4 months after implementation. So if we look at the baseline data that was collected at all 3 emergency departments between March 1st and April 30th, we reviewed 95 charts. The mean age is approximately 84 years old. 67% of the patients were women. 8% of the patients had fractures at more than one site. We had documentation of dementia on presentation in about 13% of the patients, so we can estimate that it is actually higher than that. And the main consults were to orthopedic, internal medicine, geriatrics, and social work for these patients. So if we look at the breakdown of fractures and fracture site, the majority are femur, hip, and pelvis fracture, followed closely by vertebral fracture. We also have humerus, wrist, forearms, and rib fracture, and approximately 20% are fractures at other body parts. So if we look at what was the actual documentation of pain score in those charts, what we found is that 25% of the patient had no documentation of pain score during their entire stay in the emergency department. 13% had a pain score at triage only. 44% had pain score documented somewhere during their ED stay but not at triage. And 18% had a documentation both at triage and during the ED stay. And of course we know this is what is ideal, and this is what should be, and this is what we are aiming for. If we look at the time to the first documentation of the pain score, if there was no pain score documented at triage, it was approximately 5 hours into the ED stay. So we know that the optimal target for triage and ED stay pain score documentation should be 80 to 100%, so we have room to improve. Documentation of pain score is essential in planning and evaluating effective pain management, particularly in our environment where patients are moved around and treated by multiple people during their stay. Regular documentation of pain score will result in improved quality of care. If we look at what kind of analgesia was actually prescribed to the patient, immediately in triage, only 1 patient received analgesia, so presumably this would be from a nurse's collective order. Prescription for analgesia was written for 77% of these patients. The time to the first analgesic prescription is approximately 3.1 hours, followed closely by the administration at 3.2 hours. We still note that 27% of the patient never received analgesia despite prescription. 1 patient received NSAID only. 28% of patients received acetaminophen only, 32% opioid only, 2% acetaminophen and NSAID, and 9% received acetamin and opioid, which is considered the gold standard of treatment. So this chart is a summary chart of what we discovered when we analyzed the 95 charts. So of the 95 patients, 29 had a triage pain score documented. Of those, 14 had a pain score of less than 6, so considered mild to moderate. 5 never received analgesia, and 9 received something, but the median time to analgesia administration was 6.8 hours from arrival. If we look at the 15 patients that had a pain score above 6, so considered severe pain, 3 never received anything. 12 had analgesia administered 3.4 hours on average from triage time. So it is better than the patients with mild to moderate analgesia, but again, there is room for improvement. Just to complete, if we look at where these patients were discharged, they stayed in ED. The median time was 10.8 hours. Approximately half returned home and half were either admitted to an inpatient unit or transferred back to another hospital. 10 patients, or 10% of the patient, returned to the ED within 7 days of discharge, 4 because of pain problem, 1 because of problem with the cast, and 4 for a reason unrelated to the initial presentation. So treating pain is vital. Pain, if you remembered, is considered the 5th vital sign. In addition to reviewing chart, we surveyed nurses to understand their reality, and most of you probably filled out one of those questionnaires. The questionnaires were distributed to assess attitudes, knowledge, and behaviors of pain management using measures of self-efficacy. We distributed to approximately 75% of nurses on each site, and about 50% of you completed the survey, which is considered quite good, so thank you for that. So what did you tell us? We asked you to identify barriers specific to healthcare professionals, systems barrier, as well as patients and family barriers when it came to pain management of older adults. So if we look at the barriers specific to healthcare professional, lack of ability to manage pain in a cognitively impaired patient was number 1. And by quite a margin. Collective order prescriptions, lack of education regarding pain management, fear of opioids-related side effects, and fear of comorbidities followed. To a lesser degree, concerns regarding regulatory scrutiny or surveillance post-opioid administration, and lack of tools that contribute to best practice around pain assessment and management were also mentioned. If we looked at barriers that are systems-related, time delays, and that's time delays to prescription, to administration of medication, was by far the most commonly mentioned. Insufficient manpower, as well as the actual setup of the emergency department, were also considered barriers. Finally, for patients and families, language and other communication barriers, such as, for example, when the patient is cognitively impaired, was the number 1, and some family concerns and opinions affecting assessment and management. And we know that we have families that have a fear of opioids. So we asked nurses for suggestions on how to manage these barriers and how to improve the pain management. So again, targeting healthcare professionals, suggestions included education and development of tools, prompt and appropriate pain assessment and analgesia, modification of the collective order, this came back over and over, and to a much lesser extent, communication between nurses and physician. Suggestions that targeted the system, waste decreased time to assessment and prescription by physician, increased manpower in the emergency department, changing the layout of the emergency department, and increasing the availability of equipment. And finally, suggestion for patients and family, improving the communication between patients, with patients and family. So if we go to principles of pain management, they are not different in the emergency than they are anywhere else. Pain is the most common reason for seeking health care. As a presenting complaint, it accounts for up to 78% of all visits to the emergency department. We know it is a major component of patients' experience following a fracture. Almost 100% of patients with a fracture will complain of pain. We also know that untreated pain can result in adverse physiological as well as psychological effects, such as tachycardia, fluctuation in blood pressure, cardiac ischemia, hypoxia, agitation, confusion, and anxiety, and certainly unnecessary suffering. We also know that pain is best treated early. Severe pain, once it has set in, is far more difficult to treat and control than if the pain is treated early on. Pain relief improves patients' well-being. It reduces the risk of confusion and agitation. It speeds up the return to mobility and independence. And we know that if you speed up return to mobility, it reduces length of stay in the emergency department. Pain relief depends on a rapid assessment, proper documentation, and effective treatment. So, the PAINFREE Initiative's key message is you must assess, document, treat, and reassess. and we will look at these in more details. So the nurses had lots to say also about assessment of pain. And here are some quotes. So cognitive difficulties making proper assessment challenging. It is harder to assess pain level due to possible cognitive deficits, or pain can present in other ways, such as agitation and confusion. If they're confused, the pain scale is useless, and we must rely on observation of their behavior instead. So, given this barrier of lack of ability to manage pain in the cognitively impaired, which was mentioned by a number of nurses, we are adopting the PAINAD as a tool for nonverbal pain assessment in patients who are cognitively impaired. The PAINAD is, you will hear more about it in other forums, but it is a tool that is superior to the scale using faces or colors that you may be familiar with. The PAINAD tool has 5 items on it, and the nurse is the one who ascribes a score, 0, 1, or 2 on each one of the items. The first one is breathing. It goes from normal to difficult breathing. Negative vocalization that can either be absent or can go all the way to the patient crying out and moaning. Facial expression that goes from smiling to grimacing. Body language that is either relaxed, patient is fidgeting, or is pushing away, fist or clench, and the patient is rigid. And finally, the element of consolability, where either the patient does not need to be consoled at all, or is easily distracted, or cannot be consoled or reassured. The score that is given is on a scale from 0 to 10, so there's the major advantage that it can be entered as is in our MUHC system. You will be given a pocket card as a reminder of the PAINFREE Initiative, and on the back of that card you will find a PAINAD scale with the 5 items as well as the scoring system, so you will be able to assign a score to each patient, even the ones that are cognitively impaired. So if we move on to documentation, barriers mentioned was insufficient pain score documentation at triage and during the ED stay. So we really want to reinforce the importance of documenting the score at every assessment. So starting at triage and then throughout the ED stay at each period where there should be a reassessment. So vital signs and when you have administered pain medication. You should administer your pain score in MUHC in triage as either described by the patient or as you evaluate on the PAINAD scale. I would like to point out that the PAINAD scale is an equivalent. So 1, 2, 3 is considered mild pain on our numeric scale. It is the same mild pain on the PAINAD scale, and so on until severe pain. And you should document your pain score in the pain score column on your MUHC screen. That way it will appear and is easily visible for your colleagues. Nurses also had comments regarding effective treatment. We will need a collective order to give narcotic to patients while awaiting the physician to assess patient's need for a stronger analgesia. There is an insufficient choice as well as dosages in the present collective order analgesics. There is sometimes no prescription for analgesia other than Tylenol or Advil. So this is what you told us. This is the solution to help with this problem. We will reinforce the use of the current nursing collective order. If you recall, up to 25% of patients never received any analgesia despite reporting pain. This means that some nurses are not using the collective orders, and therefore we will reinforce its usage. But the collective order will also be modified to include the possibility of opioid administration at triage or shortly thereafter. So the current nurses collective order allows you to give acetaminophen 600 mg POQ6 PRN and ibuprofen 400 mg PO times 1. Modification will include opioid administration. What has been submitted to PNT for approval, so it is not approved yet, but will be this or a version of it, is morphine 0.05 milligram per kilo IV times 1 to a maximum dose of 4 milligram. So this is considered a safe dose of opioid for elderly patients. Nurses also said, "We are concerned that opioids will cause deterioration in an elderly patient's cognitive or physical status, especially if there are many comorbidities involved. There's a lack of knowledge on pain in elderly patients. The fear to induce delirium is forever present." There's definitely a lack of education regarding pain management. We need to promote early administration of multimodal analgesia, provide information on complementary methods of analgesia, as well as encourage the involvement of patients and family members to help us partner and manage their pain better. So if we start with the safety of opioids, there are lots of myths out there, but opioids given at the right doses that are appropriate for elderly patients are effective in treating pain and will usually not cause confusion and agitation in older adults. However, not treating the pain is a cause to induce confusion and agitation. So we need to remember that. We also know that the same analgesia can be administered to patients whether they're cognitively impaired or cognitively intact. The dose is the same and it should be tailored to the elderly, not to the cognitive status. NSAIDs are not recommended for a prolonged period of time in older adult because of worsening of renal function, particularly if patients are dehydrated, and because it can induce hypertension. However, a one-time dose is perfectly safe. Multimodal analgesia is optimal when treating pain. So that means acetaminophen combined with opioids. The anti-inflammatory and opioids act in different places or with different mechanisms. So it allows for administration of a lower dose of both pharmaceutical agent than if used alone. And it provides better analgesia with less side effect. Complementary methods of analgesia also include the use of ice, and many elderly patients do not like ice. However, it works very well, and positioning as well as mobility. If we want to involve patients and family members, they can help us assess pain level regularly. They can help us by communicating the level of pain immediately to the nurse when the pain starts increasing, and they can participate with the medical staff in effective pain management, particularly in evaluating the effect of the pain medication. If we then look at reassessment, the elderly population especially poses more of a risk of respiratory distress or need close monitoring. This is what some nurses believe and say. Monitoring is necessary for respiratory status of patients and their safety, particularly in case of confusion. Patients with a fracture due to a mechanical fall may at times need to be put in the monitored care area directly. Since this is perceived as a barrier and is one of the reasons for the lack of reassessment, we want to reinforce opioid monitoring schedule. And one of the ways we can do this is following the PRN Plus automatic reminders in mid-surge for pain reassessment and adjustment, if necessary, of next dose of opioid or Tylenol. This is not used systematically. And we will come back to it in a minute. So when you should do your reassessment, I'd like to remind you that for morphine IV, which is what we will be using with these patients, you should monitor and document your pain score as well as respiratory rate and ease and level of sedation prior to administration, at the peak of action of what you are administering, so at 15 minutes post morphine infusion, and towards the end of the duration of action, which would be around the 4-hour mark for IV morphine. So how you use the reminder in mid-surge, if you go to your medication tab and the schedule column, the PRN Plus option serves as a reminder to check on your patient. Use it to reassess your patient's pain level, document the pain score, and adjust or administer the next dose of analgesia. So what about the physician? Because they will be doing the prescribing. So the physicians are also getting an educational tutorial similar to this one. The tool that they will have will be in the form of a structured prescription for analgesia in mid-surge. That structured prescription is being drafted with the help of pharmacy and geriatric experts. The structured prescription will be called Analgesia 75 Plus ED Pain-Free for use while the patient is in the emergency department, and there will also be a discharge one for when the patient is being discharged that can be printed and given to the patient. What about patients and their family? We said we would like them to collaborate with us, so they will also be given some practical tools. There will be a discharge fact sheet on pain management that you will see in a minute. The structured prescription at discharge will be printed out, so easy to read. Most of them will be given a follow-up orthopedic appointment. And finally, on the fact sheet, they will be able to find the website, a link to the PAINFREE Initiative organization, which will give them additional tips on how to manage pain and some information regarding pain medication. So this is the fact sheet that will be given to patient. It includes how to treat your pain, how to manage your medication in a better fashion perhaps than what we currently are able to give to patient, and how they should follow up if no one calls them from the clinic. So we have not been able to assess patient satisfaction per se in the emergency department around pain management, but this is a slide that summarizes patient satisfaction survey that was done around pain management during the emergency stay of patient visiting the orthopedic clinic on follow-up. So it is retrospective, and sometime quite a bit of time has elapsed between the emergency department visit and the visit to the orthopedic clinic, but nonetheless it gives us some information. So 92% of the patients said that their pain was assessed at some point in the emergency department. 85% said they received analgesia. 77% said they were satisfied with their pain management, so we have room to improve. Resources were given to patients to manage their pain at home. 100% felt that their answer had been answered by discharge, which is quite amazing. So I think we are all in all doing a fairly decent job, but as I said, there's always room for improvement. So this was the PAINFREE Initiative in a nutshell. If you have any question, please speak to anybody on the team regarding your questions or concern. And I thank you for listening to this presentation.